Delighted to introduce Veronica Pollard, who's a tissue viability nurse from NHS Greater Glasgow and Clyde. And Veronica's going to talk to us about, well, it's a carer's story, learning from a serious adverse incident review.
I'm Veronica Pollard. I'm an acute-based tissue viability nurse within Greater Glasgow and Clyde. And I've been asked to do this presentation this afternoon, which is about learning from a serious adverse review from a carer's perspective. So for those of you who may not be aware, a serious adverse event review, or SARE, is undertaken after there's been an unexpected incident causing harm or potential harm. So the incident is reported, and then we use the DATIC system, and then depending on the level of harm, this would trigger a SARE. So a SARE may be something that's, you may call, a SARE something slightly different. And however, within Greater Glasgow and Clyde, we refer to the adverse event review as a SARE, so I'll use this term throughout the presentation. It may be undertaken after medication errors or patient falls with harm, and the other, or if there's been delays in treatment, but also after the development of avoidable pressure damage. So within Greater Glasgow and Clyde, sorry, I'm just going to move this wee bit on my screen so I can see, our policy states that all avoidable healthcare acquired grade 3 pressure ulcers should be considered for a SARE, and they're mandatory for avoidable grade 4. And I should have said as well at the beginning, we use the term grade and not a category for pressure ulcers within Scotland. So let me just move this along. So the importance of SAREs, we review SAREs as to help identify the root cause of an incident and identify an action plan to correct and improve to help patient safety. It's also vital for continuous improvement of our practice and for quality assurance. And it's part of our organisational duty of candour. So what happens in a SARE? Well, we take a consistent approach for each one, and a review team is developed, and that team is usually made up of senior clinical staff who have not been involved with the incident, so often from out with the sector involved. And sometimes that review team will also include relevant specialists. They will gather information from the clinical records, nursing notes, medical notes, bedside notes, etc., and take specialist advice. They'll also review relevant policies and guidelines to ensure that procedures were followed correctly. They will also have discussions with staff involved to get their recollection of the events before, during, and after. And also, which is very important, from the very beginning, they will engage with the patient or their family or next of kin to gain their insight into the incident and give them the opportunity to ask questions. The review team will then provide a report with recommendations if appropriate. And that final report will be sent to the family. Now, the family can have as little or as much involvement within the SARE process as they wish. It is completely down to them. So they would be informed of the process from the very beginning and be asked to, provide their input. They can either, as I said, they can have as much involvement as they wish. Sometimes they would come to the hospital and speak to the review team. In other incidents, it's maybe just been through telephone and email communication. We try to be as open and as honest as possible for transparency. But also this communication often then opens our eyes a bit more to what we can see from just looking at the from the documentation. So what's written down doesn't always correlate with what the patient or their family have interpreted of the events. So that's why it's so important we have this communication open. So learning from our SARE, our theme is what matters to me. And for me, this is what we're asking the patient or their family through the SARE process. What mattered to them? What didn't we get right, and what could we have done better? So the story I'm going to be sharing with you is Rob's story. Rob developed a grade 4 pressure ulcer whilst in hospital within Greater Glasgow and Clyde. During his stay, he was moved across sites and through several wards. And although the pressure ulcer only developed in one ward, we failed Rob in several areas. Unfortunately, Rob passed away after he was discharged home, so it was his carer, who was his wife, who was heavily involved with the SARE process. And from the very beginning, she was very keen that the learning from the incident was to be shared widely. She kindly agreed to be recorded for an interview for us to share with staff, and we would like to share this with you now.
Well, I looked after my husband for 28 years, and whether he went into respite or whether he was in hospital, I only ever wanted people to listen to both of us. More so him, because although he was physically disabled, he wasn't mentally disabled, and he knew what was required in his care. Well, one thing, the very first thing that happened was that on the admission form, when he was admitted, they didn't record the correct information as to what I had said about what was wrong with him at the time. And unfortunately, I didn't find that out until I got his medical records, because I hadn't seen that form at the time. But being physically disabled always posed its challenges for staff. Well, there was actually quite a few things that really didn't happen when he was in hospital. And the reason that I actually put in a formal complaint, and I did think long and hard about it, but I just felt he was let down. We were both let down, because he was frustrated and I get frustrated when I see him struggling a bit. He ended up with a bed sore, and that was the main reason for my complaint. As I said, I'd looked after him for 28 years, and he never once had a bed sore. I refused to accept that, and that was why I put in the complaint. This is where probably listening comes into effect, because what was said and what was recorded were very different in lots of aspects of his care. He was moved about quite a lot, so that's where some inconsistencies come into effect as well, because things that were said in one word didn't go to the next word. I went through his medical records with a fine-tooth comb, and I also had a good look at the NICE guidelines for care for a vulnerable patient, which my husband was. And I found that the guidelines weren't followed, and in a lots of cases, the paperwork wasn't completed for up to 4 weeks later. It affected his mental health, I would say, as well as his physical health, because Rob wasn't in the habit, although he was physically disabled, he wasn't in the habit of being in his bed. He got up in the morning, he was in his wheelchair, he went out and about, and he went to bed at night. And that was his life. The only time he was in bed is if he had a cold or a urine infection. That was it, right? He was never, in bed full time. And as he was improving in hospital, getting up was making him feel better, because that makes him feel, I'm on the mend, I'm getting out, right? I said on loads of occasions, you need to get him up out of bed, because that makes him feel better. And due to staffing pressures and everything else, it didn't happen. And he got worse, because he was being kept in bed. The other side of being kept in bed for somebody with MS is that his contractures in his legs get worse. Well, there's several things that happened to him which to me, should have been person-centred care. One day I came in to visit him and he was lying with his face against the bars in the bed. And I asked him what had happened, and he said, I fell over not long after they had moved him. And I have been lying like this for an hour, because he could see the clock. And he said, I've been like this for an hour and nobody's been to see me. He couldn't reach the buzzer because the buzzer wasn't, with him falling over, it wasn't in a place that he could reach, but he was having problems with hands and things anyway, so whether he would have managed that. In terms of personal hygiene, it was very much lacking. He had been in hospital for 10 weeks and had never had a shower. And when I asked about having a shower, they couldn't do it because they didn't have a proper chair for him to sit in for a shower. And that absolutely appalled me, because anybody, any of us, wouldn't go 10 weeks without a shower. And you know how you feel when you've had a shower? You feel so much better. Even the illest person would feel so much better. I did manage to get his hair washed after 8 weeks. So, and the difference that it made was tremendous, because I went in, he was sitting up, his hair was lovely, and he was beaming because he'd had his hair washed. Think what he would have been like if he'd have had a shower. The other thing that bothered me about his care was that because he was on a feeding tube, dental health care was really important to him anyway. But he ended up with teeth that looked like something out of a Dickens film. And that's the only way I can describe it. There was green, like plaque all over the front of his teeth. And what was happening was the nurses would come. Sometimes it was done. Sometimes it was half done. We'll be back, we'll finish it. They never appeared. And I would be literally scraping the stuff off his mouth. And that was something that was really important to him, because he'd always tried to look after his teeth. In terms of his mouth care, he had thrush, and there was about half an inch of thrush in his mouth when he came home from hospital. Well, I would like to see improvement in somebody that is as vulnerable as Rob, right? Because that person could be somebody that you love and is in hospital. And, you know, it's all about just care. Caring is what you do. I'm a carer, but I never wanted to be a carer. But you have to look after somebody and follow the procedures that you're supposed to follow. Listen to what's been said by the carer and the person that you're caring for, and follow your guidelines accurately and record what is being said to you. Not what you're assuming is being said, what is actually being said. Give the person-centred care that you talk about, but sometimes it's very lacking. Well, the admission form, when I read it, it said that, well, I'll tell you what I said what I'd said to the nurse. He'd had, his bot was red, right? His coccyx bone was pretty tender, right? But it had problems, diarrhea and etc. And I said, it's very, very red. It's not broken. He doesn't have a pressure sore, but keep an eye on it. And I explained how I had been looking after it, which was fine. When I eventually saw the notes, there was no pressure sore ticked, but there was ambiguity in the way that it had been written down. When he came out of hospital, he was going to be bedridden. When Tissue Viability visited our home, they more or less said, you're going to be in bed for a year, if this will heal at all. Now, for somebody that wasn't ever in their bed, was going to be stuck in bed, not being able to get up, go out in their wheelchair, just live as normal a life as he possibly could, he wasn't going to be able to. And I saw a big drop in his kind of demeanour after that day, because he knew he had a fight. He was a fighter, but it just, he felt really let down, I think, because he'd never had one before. And that probably helped to finish him off, to be honest, you know, because he didn't see any quality of life being stuck in bed. In one of the wards that Rob was in, there was nobody that really talked, and the telly wasn't working. And I asked him, I said, what's wrong with the telly? And he said, oh, it's not working. He said, and you know, what do I do? He was literally lying in bed looking at the ceiling. And I thought, this isn't doing him any good. So I tried my best with the ward, but was told that it had been, this I think was May, and they had put a request in the previous November and nothing had happened. And it was actually coming up to the royal, the coronation, right? And he said to me, did you have something to do with this? And I said, well, I did. I said, but, you know, he needed that stimulation. He has nothing else. And even at home, telly was what he did. He enjoyed anything and everything on the telly. So I managed that, but that was a big thing for him. When, for Rob, being in hospital, as soon as he was in a wheelchair or getting to sit up, he knew he was on his way home, because that's what he did when he was fit and when he was coming home. So that is really important for somebody. Again, it was a bit iffy on the recording of that. Some wards had it as he's up during the day, which was what I had said. But the last ward he was in had it that he was bedridden. Even although he would say, can I get up? Wasn't always possible due to staff. But for somebody in Rob's position, that was a big thing, because that meant he was on the road to coming home. Exactly. Actually listening and recording properly. And sometimes it was very frustrating as a carer, because that was always my bugbear.
What mattered to Rob? He wanted to be listened to. He should have had a care plan centred around his needs and not the same care plan for any patient with a disability. He should have had better personal care. And Rob and his wife wanted more information and better communication between wards. So that video, it always gets me a wee bit emotional, and I think because I've been practicing it, I've not been listening to it, and just hearing that lady's voice again, it really kind of triggers with me. But this learning is not just about the pressure ulcer prevention. The learning we can take from a SARE is that we need to include our patients more in the development of care plans and ensure that they're involved in decision making. So time pressures in our wards are affecting everybody, and families would appreciate recognition if unable to get a task done, rather than ignoring it and pretending it wasn't supposed to be done in the first place. So when we share Rob's video in our in-person study days, and we ask staff how it makes them feel, sad, upset, frustrated, but also highlights about how it's the very small things that we can do in our day-to-day practice that can have the biggest impact for our patients and their families. So from the SARE process, we are reviewing our documentation and, we're trying to make improvements in our work. However, sometimes just speaking and getting feedback from our families and getting that carer's perspective, as Rob's wife has very eloquently put this message across in a way which is far more powerful than any reading of notes or input from a specialist, can really provide. And that's where, we feel as though this is a valuable lesson to take forward. So for key takeaways, SAREs absolutely improve patient safety and our quality assurance, but learning from the incident drives future improvements. And it's important that carer and patient and carer involvement is crucial for transparency, but it also, and more importantly, brings forward themes that may not be clear from our documentation. Okay. Now that powerful video has been uploaded to the resource page for you to use, and I'm sure many of the issues highlighted would not be unique to Greater Glasgow and Clyde. I'm really grateful for your listening. I'm sorry it was quite a somber video, but try and end in a positive. And my colleague always likes to put a quote into her presentation, so I thought I would be a copycat and do the same. And I like this one, that we are what we repeatedly do, and excellence then is not an act but a habit. So I would always say, for this theme of what matters to me is that we're always striving for excellence with our care. So thank you very much, and I'm more than happy to take any questions that anyone might have, or even just comments.
Yeah, thanks, Veronica. Yeah, there's a bit like when you've presented this in maybe study days in your area of work. Again, yeah, people are commenting on how it's made them feel, the emotion. It's very sad, very powerful messages. Um, but it reinforces, doesn't it, this whole active listening thing. And there's always reasons why. I do a lot when I teach on active listening. People think they listen, but actually they're not actively listening. It's that little voice that's in their head that's distracting them. They're not really focusing. And, people come up with, maybe you could put in the comment in the chat, folks, as to whether you feel you actively listen or what you think the barriers are to active listening. And, I know time will come up. I know time will come up in the chat. But if we don't get it right, we're going to continue to see these stories, aren't we? Really?
Yeah, yeah, absolutely. And I know that, even just in the ward, obviously I'm acute based, and these issues will be the same in community.
Yeah.
But it's that way where you're trying to take information and speaking to families, but aware of you've got other things you need to be doing as well. And it's, all of these things that are going through your head as well. But I like somebody's put a comment about empowering families. Sorry, I've
Hmm.
scrolled down now and I can't see it, but I thought it was
Yeah. Yeah.
a great suggestion. And I think with the demands, um, especially in the acute settings at the moment, I think that is a fantastic idea that we do. And although it's not for every family, there's certainly, I know that a lot of families love to be involved and building that relationship with the healthcare staff that are caring for their loved one as well.
Well, I think that does happen in a lot of hospitals, and it's, I can be a cynic here and think, well, actually, that helps them out, and they've got staffing issues, family members that come in and end up bathing patients, washing
Hmm.
their hair, changing their bed, is that right? And okay, if they want to get involved and they get the guidance and the support to do that, but we shouldn't be using people
No,
as a cheap or a free pair of hands.
absolutely
And
not.
the comments you made about not being showered for 10 weeks, not having your hair washed, just not having a decent quality of life. It's heartbreaking, isn't it, really?
Absolutely.
And it
And
makes me ashamed and embarrassed that actually this is NHS and we
mhm,
can't do these simple things. I mean, I'm old school, I was in the NHS for 40 years and I can remember, the one of my best things was when I could bathe somebody when I was a community nurse or even in a hospital, put them in fresh clothes, pajamas, give them a shave, do their teeth, do their hair, and just that absolute satisfaction. And the patient felt so good with having had care like that. And I'm not saying we this is possible again, but we need to be considering these personal things, don't we?
absolutely. And for it to go on for that length of periods of time,
Yeah,
I think
yeah.
that's the most alarming for me. Fair enough, there might be a day or two that we don't have time to shower our patient, but for it to go on, and I think that's what can happen with the acuity in our wards now when patients are moving from ward to ward, different staff looking after them all the time. There's just not that same relationship.
Your comment about when he got home and being told that, it could take a year to heal and he's going to have to be in bed for that period of time. I mean, how demoralizing for
Yeah.
somebody. And I think, we we have to get a balance, don't we? And again, it seems to be, you know, when people have got severe pressure damage, you know, that is often part of the plan, you know, bed rest, repositioning, high-end mattress. But what impact is that going to have on quality of life? And even if we can just get people up for meals, short periods of time, but you know, on a really high spec cushion, because that's where we often go wrong, is they've got an all singing all dancing mattress on the bed and then the cushion isn't catered for.
Yeah.
You know, getting OTs in for the proper posture and seating, because I mean, I'd love to go to bed for a couple of days, you know, and have a little kip and all the rest of it, but the thought of being in bed for a year,
No. Yeah. No,
you know,
especially if your quality of life has been based on
yeah,
getting up and being
yeah,
sociable. Yeah, absolutely.
yeah,
So
yeah,
we should always
definitely.
be striving for getting it, and that's all part of that patient-centered care, you know, getting it what's right for them.
It's interesting the comment that was made from his wife about she'd read the nice guidelines and then realized that they weren't being followed, because it'd be interesting to know just how many patients or carers have ever read a nice guideline, and we shouldn't expect them to have to do that. You know, it should be, I know that we have patient information leaflets that should, you know, summarize what's expected in terms of
Yeah,
a nice guideline, but you know, that that clearly hadn't been communicated about what should have been happening.
yeah.
Um,
And whether, because I think as well with the SARE process, I think what can sometimes happen is that there's a bit of a delay between when that all starts, and that's something that our board are definitely working on to improve, that it's triggered sooner, so that there's not this delay, and so that the family are involved from the very beginning. Um, Historically, it was sometimes there was a bit of a delay before people were recognizing that this should have been a SARE. And by that point, there may have already been a patient complaint in. So already there's barriers there to, you know, speaking with the family, because they've put a complaint in, they feel, you know, already they're disheartened. Whereas if we're open and honest as soon as the incident has happened, it can often improve the relationship, you know. And yes, we're still going to be giving out the same information, but it just comes in a different. And I think that's what's happened here, is that from the very beginning, we've been open and honest, and that is why Rob's wife was so keen for the learning from it, you know, to be shared, and not just at a local level, not just for the staff involved, but also very aware that this could have happened within several wards within Greater Glasgow and Clyde, so it should have been shared widely.
is it unusual that a carer, a family member, or a patient wants to be this involved in this process?
I, I would say it's maybe now something that we would discuss more as an option, you know, as part of our learning from the review, you know, that we would maybe suggest to them. It's not something that we've had in the past, you know, we've not been able to develop a resource or anything based on them, but certainly, you know, we would always use positive and negative comments. You know, we would always bring them to our clinical governance meetings and things and make sure they're shared with the teams. But as something as so formal as this is the first we've had, but it has been so powerful that I think it's something we would definitely try and use again for other themes, not just pressure ulcers.
This is it. It's the wider sort of incident
Mm-hmm.
spectrum, isn't it, really?
Yeah.
Any tips on, you know, people thinking we need to do something like this, how to sort of go about it, and who you need to get involved to support it being done in such a positive way?
Yeah, so it was led by one of our chief nurses, and then just got involved with our medical illustration team, you know, to help with the recording of it. Um, that was really it. And then we've just tried to share it as widely as possible.
And you say that this is being made available. Is it as part of our resources to stop the
Yes, it
pressure?
is.
Yeah,
Yes, it is.
yeah. Someone's asking if they can
Mm-hmm.
listen to it again, so it will be available on our website as a resource for part of the
I
Stop the
think
Pressure.
Veronica put the link in the chat as well.
Oh,
Yes, it
brilliant!
is. Uh-huh.
Great. Okay, thank you. I don't think there are any. Oh, the link is further up. Thanks, Dawn. I missed that one. Yes, the link's in the chat if somebody wants to go in and save that and listen to it and share it. I think it'd be good if it can be shared because, as you said, it's such a powerful story. There's no other further questions or comments, Veronica. So we'll draw that to a close now. But thank you
Thank you.
again. And if ever you see his wife again, thank her as well, because I think this is really important that we hear this story.
Yeah, thank you.
Thank you.